Good afternoon, everybody. I'd like to welcome all of you to our next APDR National Virtual Noon Conference session. My name is Dr. Hart Beatty. I'm the chair of the Education Committee for the APDR and the Neuroradiology Fellowship Director at Boston University. Today, I'd like to welcome two, again, amazing speakers and dedicated educators to the session. I was telling them earlier today, this is session number 53 and 54 for our series. So we've come a long way and we appreciate everybody who has participated, both as attendees and as speakers. We're really proud of the things we've accomplished here. Just some housekeeping items. Your microphones will be muted as you enter just to ensure optimal quality for the participants. And if you do have questions for the presenters, we ask that you use the Q&A tool through Zoom. In addition, as you know, the webinar is being recorded and hosted on the APDR YouTube channel to be watched at any time, and the comments and questions will be recorded as well. I'd like to show our two speakers for today, Dr. Neel Madan, Assistant Professor of Radiology at Tufts Medical Center and the Radiology Residency Program Director there. He'll be speaking, starting the session off on Open to Close, the Complex World of Spinal Dysraphism Made Simple. And he'll be followed by Dr. Craig Morris, Professor of Radiology at UT Southwestern Medical Center and also the Radiology Residency Program Director, who'll speak second on intracranial findings in common infectious diseases in children. So we are so proud to have both speakers. So without further ado, I'll stop sharing my screen and I'll ask Dr. Madan to take over his screen share and begin his presentation.
Hi, thanks for having me. So we are going to talk about the complex world of spinal dysraphism, and hopefully I'll be able to break it down for you. We're going to review the pathophysiology and spectrum of spinal dysraphism. We'll look at the various imaging findings, both in utero and postnatally, as well as implications for preoperative planning, and then also discuss postoperative imaging in spinal dysraphism. Spinal dysraphism is a heterogeneous group of disorders that's due to incomplete midline closure of mesenchymal, osseous, and or nervous tissue. It's seen in about 1 in 1,000 pregnancies worldwide, although it's less in developed countries due to better nutrition related to folate supplementation, as we've all learned about in medical school. There are a number of other risk factors, which also include genetic predispositions, certain drugs, especially anti-epileptics, as well as maternal diabetes, which can be associated with a specific form, caudal regression syndrome. Now, the clinical features of spinal dysraphism are going to vary depending on whether we're talking about an open or closed spinal dysraphism. Spinal dysraphism is generally not fatal, but can be associated with neurologic impairment, and it's usually below the level of the malformation. Typically, we'll see sensory and motor deficits, as well as incontinence. Closed spinal dysraphism are usually asymptomatic, and the clinical manifestations that lead us to the diagnosis are going to be either related to cutaneous findings. These might be things like a hair patch, or related to a skin discoloration or a palpable mass. And we're also going to be looking at it when we see evidence of a sacral dimple. Now remember that it's very common to see dimples in kids, in neonates. So we're really looking for ones that are atypical, either in an atypical location, higher above the anal verge, or off midline. And then finally, we're going to be looking for symptoms of tethered cord. Now the tethered cord syndrome, sometimes also referred to as the Titan phylum syndrome, is a presentation that's very common for all forms of spinal dysraphism, both open and closed. Patients will typically complain of back pain, lower extremity pain or spasticity. They can have worsening urologic function as well as incontinence, increasing scoliosis, as well as gait dysfunction. This is due to an abnormal tension on the conus by the phylum terminale, which results in ischemia and impairment of oxidative phosphorylation. It can clinically have symptoms of tethered. We can have patients who have symptoms of tethered cord who could benefit from surgery but have no imaging findings of spinal dysraphism on MRI. So it's important to realize that there are patients who have this condition but without any imaging manifestations. But in our case, we're really looking for this as a potential symptom that might then point to further evaluation, looking for evidence of spinal dysraphism. Now, open spinal dysraphism, at least in developed countries, is generally diagnosed prenatally. It's going to be first seen on our quad screen with an elevated AFP, which is used to detect open spinal dysraphism. It will also be seen on prenatal ultrasound by directly observing the meningocele or the myelomeningocele, indirectly by identifying stigmata of Chiari-2 malformation, be it the posterior fossa malformation, calvarial malformations, and then fetal MRI will be used to better define the abnormalities. Closed spinal dysraphism generally is diagnosed postnatally, again, due to the cutaneous abnormality or clinical symptoms, the concern for tethered cord. Now, here's our challenge. On the left is my first child, and when she was a baby, the question is how do you decide if she's incontinent? Or on the right is my son as he's learning to walk. How do you decide if he has a gait problem? And so the signs of tethered cord, at least in young kids, can be very challenging and make it difficult to determine if they, in fact, should get imaging. And so you're looking for other manifestations. Now, the embryology of the spinal cord development, we're going to only mention briefly, but these images are showing a view looking down at the ectodermal plate. Remember that the ectoderm is going to form both the skin and the nervous system. And as time goes on, there is a series of events that leads to the formation of the neural elements. Now, what I'm going to show you on the next slide is really a cross-section through the neural plate, and that's going to help us understand how the tissue separates. So here we have the ectoderm tissue, and the tissue that's going to become the neural element is here in the center. It's going to be called the neural fold. It's going to fold downwards at first, and over time we're going to see it basically cinch off as the skin will approach itself, and the neural tissue will then eventually separate from the skin. This is called disjunction, where you have then mesenchymal tissue coming from the mesoderm separating the skin from the neural tube and the neural elements. And a lot of the issues that we're going to be talking about are related to problems of disjunction. These are scanning electromicrographs showing a fetus as it develops. And typically, what we learn is that the neural tube starts to come together right at the craniocervical junction, and then will go towards the head cranially, as well as towards the feet caudally. And that is certainly true, but it's also important to realize that there are probably multiple points at which there's fusion occurring, and so you can have a lack of fusion at any point along the neural tube, although the most common is going to be at the caudal end, and certainly we will also have examples at the rostral end. But you can have defects along the cervical and thoracic spine as well. Now, failure of neural tube closure can result in a number or a spectrum of abnormalities. That includes anencephaly, or embryologically speaking, merencephaly, where you have an absence of the rostral end of neural tube closure. You can have it happen both in the mid-thoracic spine, as I mentioned, as well as at the lumbar end. And so anywhere along the spectrum. What we're really going to be focusing on is going to be at the most distal end of the neural tube, but just realize that there are going to be examples where the nomenclature that we talk about can apply elsewhere along the neural axis. Now, there's a secondary neurulation that also occurs that forms the caudal cell mass. And so here is the spinal element forming the sacrum, and what we see is that the caudal mass will cavitate and form the conus medullaris, the filum terminale, and the distal end of the thecal sac. In the beginning, the spinal cord will fill that thecal sac, and over time, it will ascend. And it's not that the spinal cord is ascending, but rather that the vertebrae are growing disproportionately relative to the neural elements. It's important to realize that even at birth, the conus medullaris typically terminates above the L2-3 level. And so even in a neonate, we typically will see it above that level. So now we're going to focus in on the classification of spinal dysraphism. And the easiest way to separate it is to really think about our open neural tube defects versus our closed neural tube defects. This classification system really looks at the clinical radiologic correlation, and it's important to realize that there are embryologic changes or embryologic defects that may actually be overlapping between both open and closed neural tube defects. So for example, concerns of non-disjunction or that separation of the skin from the neural tube can be seen both with open and with closed neural tube defects. So when we think about embryology, there is overlap with the clinical radiological system we're going to talk about. Now, open neural tube defects are going to be defects where there is exposure of the neural tissue with a defect in the overlying skin, and a closed neural tube defect is going to have the neural tissue covered by the skin. So we're going to focus in on the open neural tube defects first. So there are two open neural tube defects. The first one is the myelomeningocele, and this is where we're seeing an exposure of the neural placoid extending beyond the skin surface. Here we have a coronal and sagittal T2 MRI image from a fetus. And what we're seeing is this large fluid-filled sac along the caudal end of the baby that is projecting outside of the baby. Now, in this case, and the challenge sometimes we have with these cases is that since the fetus is up against the placenta here, it can actually be hard to separate that defect, that abnormality, and determine where it is relative to the skin. But we can look at all of our other images, and axial images can be very helpful here, but we can actually follow that neural element on this coronal image. Here's the spinal element. This is the lung right here. We can actually follow it into this large defect, and we see neural elements coming into this large sac, which has no skin covering it, although we can still see a margin to the tissue, but that is going to be neural tissue rather than the skin. Myelomeningoceles are typically associated with Chiari-2 malformations, and so we can also look for the stigmata of Chiari-2 malformation. And in this case, what we're seeing is, again, that herniation of the cerebellar tonsils through the foramen magnum, a small posterior fossa, that towering cerebellum, abnormalities of the brainstem, including that beaking of the tectum, and these can be associated with supratentorial abnormalities as well. Now, on fetal ultrasound, you can sometimes see the actual defect, as we're seeing here, or you can also see the stigmata of Chiari-2 malformation. Now, myelocele, which is also sometimes referred to as myeloschisis, is an exposure of the neural placoid, but it's flush with the skin surface. So if it's herniating beyond the skin surface, it's going to be called a myelomeningocele. If it's flush with the skin surface, it's going to be called a myelocele. In this case, what we're seeing is actually a patient who has a split cord, and only one of the two cords is actually coming into or related to the skin surface. And so this would be referred to as a hemimyelocele. And you can have both hemimyeloceles as well as hemimeningoceles related to open neural tube defects. So two examples, or the two types of open spinal dysraphism, are the myelomeningoceles and the myeloceles. Both are going to be related to problems of non-disjunction. And in the setting of disjunction, we have the neural fold not fusing midline to form a neural tube, and it's going to remain in continuity with the cutaneous ectoderm. The exposed neural tissue forms a reddish plate that is called the neural placoid. If it's above the skin surface, it's a myelomeningocele. If it's at the skin surface, it's going to be a myelocele. So now we're going to move from open spinal dysraphism to closed spinal dysraphism. And this has a lot more complexity to it. So the first type of closed spinal dysraphism we're going to talk about is those associated with a subcutaneous mass. In this case, we have a fetal MRI, sagittal image on the left. This is the spinal column right here. The axial T2 image is right here. This is the pelvis. The bony pelvis, you can see the iliac bones here. These are the kidneys right here. And here we have splaying of the posterior elements. Now, on a fetal MRI, sometimes it's very hard to differentiate a meningocele from a myelomeningocele. But what we're looking for is whether or not the herniation of the CSF-filled sac extends through a posterior defect, as we see here, and whether or not there is overlying skin and subcutaneous fat. So we'll be looking for that fat to cover the defect, and that's going to be a meningocele. I think this is much easier to see postnatally on this axial and sagittal T2 image. On the sagittal T2 image, we can see that neural tissue coming down well below that L2-3 level, and coming through into a fluid-filled sac that's herniating through the spinal posterior elements. But we see that there's fat overlying that tissue that reflects a covering for this CSF-filled sac. And that is going to be a meningocele. If it came through and herniated through the fat and went beyond the skin surface, that would be a myelomeningocele. Now, a myelocystocele is the next form of a closed spinal dysraphism associated with the subcutaneous mass. In this case, what we're seeing herniating through the posterior elements is a dilated syrinx. And that terminal syrinx is coming through and herniating through the posterior element. So it's not just the CSF fluid, but also the neural elements coming through it with that dilated syrinx that forms the myelocystocele. On the axial T2 image, again, we can see that dilated sac. It can be sometimes challenging to differentiate a myelocystocele from a meningocele, and so the importance is to follow that conus medullaris, identify that syrinx, and try and determine where that syrinx ends and whether or not it extends through the defect. The next type of closed spinal dysraphism associated with a subcutaneous mass is a lipoma with a dorsal defect. This is where a lipoma is tightly attached to the dorsal surface of the neural placode and extends dorsally through a bony defect. This is a problem of premature disjunction. So again, it's related to that closure of the neural tube elements and the separation from the ectoderm. And there are two forms, lipomyelocele and lipomyelomeningocele. In the lipomyelocele, the cord and junction between the placode and lipoma is within the spinal canal. So it does not, the cord itself does not extend through that defect in the spinal elements. Here we have an ultrasound image, axial image. This is the lamina on either side, and we see this echogenic fatty mass extending through the posterior elements coming closely related to the skin. On an MRI, we can see this T2 hyperintense tissue. This is the fatty mass. That's differentiated from the CSF fluid right here. We can see the fatty mass is extending through the defect, but in fact, that junction between the neural placode and the fat is within the spinal canal. So this would be a lipomyelocele. A lipomyelomeningocele is going to be where the cord and placode junction is outside the spinal canal. And so we're going to see some of that fluid of the CSF space herniating through that defect. And again, that junction between the lipoma and spinal canal, lipoma and neural placode is outside the spinal canal. And that is a lipomyelomeningocele. So that is the closed spinal dysraphism with subcutaneous mass. We've gone over the first three. Also to mention, there can be a cervical myelomeningocele. And this can have overlapping features and is similar to the thoracic myelomeningocele I showed earlier, and similar to the myelomeningocele in the lumbar spine, except it occurs at the cervical level. And some of these will have overlying tissue, but they can also be open spinal dysraphism depending on whether or not there's covering. So again, these are going to be the various forms of closed spinal dysraphism with subcutaneous mass. Now, you can also have closed spinal dysraphism without subcutaneous mass, and these are going to be divided into the simple and complex forms. The simple forms are going to be easy to think about. These are where we have abnormalities that are really confined to the spinal canal. In this case, we see an intradural lipoma in this patient where there is a soft tissue mass that is related to the dura. You can also have lipomas related to the phylum. as we see on this axial, ultrasound. This is a sagittal ultrasound image. We can follow the phylum down. We can see this lipoma is related to the phylum. On the axial T1 image, we see this fatty mass showing up as a T1 hyperintense lesion, iso-intense to the fat in the epidural space and the subcutaneous tissues, reflecting a fatty phylum lipoma. We can also get a thickened or tight phylum terminale, and this is going to show up on an ultrasound as echogenic tissue that is thick, or will show up on our MRI as a thickened phylum terminale. Now, the persistent terminal ventricle is sometimes put in the spectrum of closed spinal dysraphism, but some will also consider this to be a normal variant. We'll sometimes see that the very distal end at the conus medullaris, we'll see the central canal is a little bit dilated, and that's sometimes referred to as a persistent terminal ventricle. These can get quite large, and so can be sometimes mistaken, or the concern can be raised for a potential cystic mass in the distal phylum, in the distal conus. So whether or not this is a closed spinal dysraphism or really a normal variant is an area of debate. So these are going to be the simple forms of closed spinal dysraphism. One last brief mention, there can also be incomplete closure of the bony elements of the spine. We'll see this very commonly on x-rays, on CTs, and some people will also include this in the spectrum of simple spinal dysraphism. Sometimes the term spina bifida occulta is used in this evaluation, especially referring to it on radiographs, although I would urge you to exercise caution in using that term, because for many clinicians, as well as patients who read their reports, that creates a lot of confusion about whether or not any further workup is needed. And so on x-rays, just seeing an incomplete fusion of the posterior elements in and of itself is not a reason for a patient to need a CT or MRI. And oftentimes on CT and MRI reports, we don't even mention the incomplete closure of the bony elements. So again, just caution about whether or not that is part of the closed spinal dysraphism spectrum, and caution about using the term spina bifida occulta, because it can lead to unneeded, unnecessary workups. We're now going to talk about the complex spinal dysraphisms. So the first one is the dermal sinus tract. And these are oftentimes best seen on a sagittal T1 image. These are going to be a midline persistent connection between the spinal canal and skin surface. This is again related to a failure in disjunction, but is going to be very focal. These patients are at risk for developing infections, and so these typically will be treated with surgery. They can also be seen on T2 images, but oftentimes that tract can be harder to make out. These can be seen anywhere along the neural axis, so typically seen along the lumbosacral spine, but we can see this truly anywhere. And so another location where we will see them is actually at the rostral end, related to the nose and the very rostral aspect of the skull. Diastematic amelia, or split cord malformations, is another form of a complex spinal dysraphism. And in this case, it's divided into two types, type 1 and type 2. Both are going to have hemichords, so the spinal cord is going to be split into two. And the real differentiating factor is whether or not there's one or two dural tubes and associated one or two separated subarachnoid spaces. In the type 2, at the very distal end, there will be oftentimes a fibrous septum through the inferior cleft, whereas in the type 1, there oftentimes will be a bony or cartilaginous separation at the inferior cleft. In this case, what we're seeing on the CT image is that bony cleft. We see the two spinal cords in their own separate dura and subarachnoid spaces, versus the type 1, where our CT myelogram shows the contrast extending around both of the two cords, and we have one subarachnoid space and one dural tube. Caudal regression syndrome is another form of a complex spinal dysraphism, closed spinal dysraphism, and this is related to incomplete formation of the spinal cord and is seen with a blunt termination of the spinal cord and associated with tethering of the cord. When you see a spinal cord that has this blunt termination, the first thing you should think about is caudal regression syndrome. It's a very typical appearance. You don't see that smooth tapering of the conus, and you're going to be looking next for evidence of sacral agenesis. In this case, it's much more severe. It can be variable, so sometimes it can be a little bit harder to pick up on initial view, so you want to look for it whenever you see that blunt spinal cord. These will also be associated with malformations of the lower extremities. All right, so we've covered the closed spinal dysraphism without subcutaneous masses, both the simple and the complex. And we've covered several examples: the disorder of non-disjunction seen with dermal sinuses, disorder of midline notochordal integration. We talked about the split cord malformations. And then we talked about the disorders of notochordal formation, including the caudal regression syndrome. So different genetic etiologies for some of these complex closed spinal dysraphisms. In terms of surgical management, just to spend the last few minutes talking about this, open spinal dysraphisms will typically go to surgery. It's generally performed within 72 hours of delivery due to increased risk of infection. The goal is going to be to approximate the edge of the open neural plateau in the midline to reconstruct the neural tube. Sometimes it may require skin grafts or muscocutaneous flaps, and patients will oftentimes need VP shunts for associated hydrocephalus. The other important thing to realize, especially if you do fetal imaging, either obstetric ultrasound or fetal MRI, is that for open spinal dysraphisms, there are centers in this country that will treat these surgically in utero. There are inclusion and exclusion criteria, but it is important to realize that there may be intervention that is entertained for patients where the diagnosis is made in utero. And so it's important to make the diagnosis efficiently and also to make sure that you're aware of some of those inclusion and exclusion features that would lead to the consideration for surgery. It is not all patients will qualify, but it's something to be aware of. Closed spinal dysraphism typically are performed only when there is neurologic compromise associated with tethered cord. That being said, as we discussed, it can be very hard for parents to know whether or not their child is incontinent or having trouble with potty training or having difficulty with walking if they have a clear abnormality. And so then the question will be, what is the likelihood of those symptoms developing, and is it worth intervening surgically before those symptoms develop to allow the child the best opportunity to become continent, allow the child the best opportunity to be able to walk and function normally. Several complications that can occur after imaging. So CSF leaks and dermoids are going to be two of the things we're going to be looking for. Pseudomononucleosis can develop both early on and in a delayed fashion. We're going to be looking for fluid and that communication. These patients can develop signs and symptoms of a CSF leak. Patients can also get inclusion dermoids, and these can result in tethering of the cord. Recurrent tethering of the cord may be difficult to diagnose in MRI because what we're looking at is post-surgical changes. So is the cord actually dorsally positioned and tethered related to what was left behind, or is has there been development of scar tissue that's resulted in retethering? So our job is not to completely exclude the possibility of recurrent tethering, because that's going to be based on the clinical features, but look for signs and symptoms that might point towards retethering. And that's going to include syringomyelia, dermoid or other mass in patients who have had previous surgery. Here's a patient with syringomyelia, and syrinxes can be associated with all forms of spinal dysraphism. It's thought to be secondary to a tethered cord and can create increased tensile stress and result in the formation of a syrinx. There's a lot of overlapping clinical features with tethered cord, but if a patient has a syrinx, the first thing the neurosurgeons are going to do is typically try and treat the underlying spinal malformation. But if they have treated the spinal dysraphism adequately and the patient has an ongoing syrinx, they may need to surgically intervene with the syrinx. In terms of imaging strategies for open spinal dysraphism, again, it's going to start with that screening ultrasound. MRI is going to be used for further characterization, and we're going to be using it in the evaluation of the post-operative patient. For closed spinal dysraphism, if we're dealing with a neonate or infant, we're going to start with spinal ultrasound, but then go on to MRI, both preoperatively and post-operatively. So in conclusion, I've covered the classification of spinal dysraphism, shown you examples of both open and closed spinal dysraphism, and the many flavors. I hope the next time you see such a complex patient that you'll have a way to organize your thoughts and approach the imaging findings. Thank you.
Thank you so much, Dr. Madan. Truly, truly grateful for your time and giving that great talk. Next, I'd like to invite Dr. Morris to share his screen and to begin his presentation.
All right, it's great to talk to all you guys, and I actually shortened my title a little bit because I wanted to say it in one breath. It was a little bit too long. We're going to talk about intracranial complications of infections in children. So, boy, this is a great world for ENT surgeons, right? This lecture could be entitled, Mind Your Eyes, Ears, Nose, and Throat. And even as a neuroradiologist, I can figure out that posterior periauricular space is not normal. In fact, that's ready to burst, isn't it? So, kids are just kind of walking germ machines. And I've worked in children's hospitals for years now, and I know that. So kids present with all these things: sinusitis, otomastoiditis, orbital cellulitis, and sometimes infections that have an immune-mediated response that affects the brain. So when these kids have these infectious processes that affect the brain, they often present with this common denominator, common diagnosis in the emergency department: altered mental status. So I love that term. When I go back and look in the medical record, you see all of these things not uncommonly. It's headache, lethargy, weakness, seizure, confusion, vertigo, somnolence, unresponsive, all of that. The one I really like is the kid is just not right. So sometimes that's what we see when they have these complications. So the ED sends these kids to us, and we see them as radiologists with the head CT. So this is what I like to say is CT is usually, that's our first screening study. So they get a chest x-ray and a head CT. So I like to call the head CT the chest x-ray of neuroimaging, right? I mean, it works, right? 4 ventricles, 2 atria, blood supply, neuroradiology rules. But anyway, the findings, it's pretty tricky because this is our screening study, right? And so many times these kids can have significant intracranial complications related to infections that present very subtle findings on the CT of the head. And so we have to look for these things like shift of structures. Maybe things are just moved a little bit, or there's just subtle asymmetries. Or sometimes you look at it and say, wow, the anatomy is just slightly distorted. And you get that as you grow and through your career, and you develop that mental picture of what things should look like. And sometimes you look at these images and you say, it just doesn't look right. Maybe there's subtle density changes, or maybe the extraaxial spaces are a little widened. But we have to learn to look for those things very, very carefully on these screening head CTs in order, as you're going to see in a few minutes, to pick up substantial findings that can be life-threatening in many cases. So we're going to start with a good case. So the history is true. 13-year-old male with 1 week of headaches and an economy of words here, altered, right? Okay, so I'll let you look at some images. So give you just a few seconds. So we have an axial unenhanced head CT. So, and then we have the coronal reconstruction. So just take a few seconds there. You're in the emergency department and you've got this kid with headaches and altered. A lot of findings here. Okay, so let's look at some images slightly higher up. So think about all the things we just talked about subtle asymmetries, density changes. This kid's got some pretty significant findings. Side to side, the brain should be pretty symmetric side to side. And that's always a very, very helpful clue to us of pathology. All right, so bone windows. So bone windows are always critical. So I'll tell you, whatever you read, whether it's a child or an adult, always look at your bone windows. There is so much disease, particularly in this talk, when we talk about sinuses and ears, they're critical for us. Okay, so I'm sure you guys have picked up the findings here on those. So let's go back and look at them. Okay, so arrows are pointing at the findings. So on the axial images, there were a pretty obvious finding. There's pneumocephalus, right? So if this kiddo has not had head trauma or recent surgery, or somebody injected the fecal sac with a lot of air, that pneumocephalus shouldn't be there anterior to the frontal lobe. So that tells us there's got to be some kind of communication with one of our air-containing spaces, like the sinuses or the ears, right? So that's abnormal. So let's look at the coronal images. So again, we're going to talk about abnormal extraaxial spaces, abnormal densities. So there's a lot of asymmetry between the right and the left side. So this is normal on the left. So you see the normal subarachnoid space, even here in the parafalcine region. Nice, normal subarachnoid space. Kind of see the sulci here. You don't see that on this right side, okay? So even the parafalcine region here, there is increased density in this extraaxial spaces, and also over the right frontal lobe. You see all this increased density. That is not normal. That's never normal. So let's go back and look at those upper images. So same kind of findings. If you look at the difference between the left and the right side, there are a lot of subtle differences. So again, normal CSF spaces, increased density. You see the normal sulcal spaces here. Sulcal spaces are effaced on that side. So this is really critical to see and to think about. As you look at these screening CT heads, you've got to look for these kind of subtle asymmetries. So you saw the findings on the bone windows, right? Pretty obvious large air fluid levels here in the frontal sinuses. So what we've got to do is put all these findings together and come up with a pretty good short differential for the emergency department. That's our job as radiologists, to communicate this to the emergency department. So we got to tell them what we think it is, and then we also have to tell our colleagues in the emergency department how urgent is this finding for clinical management. And we have to be very specific about these things to our colleagues. And also we need to tell them what should they do, all right? So, and then the other thing we have to do is document in our report what we said and to whom we said it. But so we had pneumocephalus, right? That concerned us. We had air fluid levels in the frontal sinuses, so we're thinking that may be the source. We had unilateral sulcal effacement. That really is very concerning because that tells us there's mass effect, right? And we had these asymmetric extraaxial spaces. So you could look at this case and say maybe it was just purulent meningitis, but I think those sulcal spaces were effaced. I think there's mass effect. I think it's more than meningitis. So my concern was subdural empyema in this kiddo. So actually I read this case. So when I talked to the emergency department, I told them specifically all these things. You know, there's pneumocephalus, there's this extraaxial fluid, there's mass effect, and there's a lot of frontal sinusitis. And I told them I'm very concerned. This kid's got a subdural empyema, and this is an urgent case, and we need to get an MRI. So what they told me was they'd in fact seen this, and they called neurosurgery, and neurosurgery had ordered an MRI. So the communication here was very clear. We knew that this was a critical case, that surgeons were on board, and everybody knew what they had to do. So let's look at, so this is kind of a nice finding again. You can see the sinusitis here, and you can see again this abnormal collection. So this was the MRI that we got. So it's pretty telling, isn't it? So these are the T2 axial flare images. There's T2 contrast in this brain. There's dark fluid, so this is T2 flare. But what you see on that right side is this subdural fluid collection diffusely around that hemisphere, and it's proteinaceous. It's bright on the flare images. And look at all the mass effect. I think that's mass effect out of proportion to the size of that collection. It really tells you that there's significant inflammatory change going on there. So the diffusion images are very helpful, right? So there is restricted diffusion in this collection, and look at what the diffusion images show us, that this is parafalcine. It's just like that CT showed us. So this is what subdural empyemas do. They tend to wrap themselves here around the brain. So one thing I wanted to point out is many times these patients are unstable, and we cannot keep them in the MR unit very long. So in fact, this is our acute stroke protocol, we call it, but we use it a lot for kids with altered mental status. The pediatricians don't know whether the kid's got a stroke or ADEM or what's going on. We do diffusion flare because we get the answer 90% of the time. We know what's going on, and we get the kids out of the magnet. And I think that's one of our responsibilities as radiologists, is to use MR as a tool to hone these sequences down to what's important and help clinical management. Okay, so subdural empyema is a pretty serious finding, and you will see these. It's generally a neurosurgical emergency, so most of the time these kids go to the emergency room pretty quickly. And that's because of all this purulent inflammatory material. It can just diffusely wrap itself around the brain and cause pretty severe mass effect quickly. So they'll get really bad cerebritis. In fact, the patient you just saw ended up with pretty significant left hemiparesis from his bad cerebritis. They can herniate, they can form abscesses, they can have destructive infarct-like changes in the brain from the severe cerebritis. So this is just a cartoon, a drawing just to show you, and this is how pus, subdural empyema, wraps itself around the brain, and this red inflamed cortex just shows you what happens with the bad cerebritis. So this is the concern about subdural empyema and why this is in fact a neurosurgical emergency. Let me show you a few more pictures of subdural empyemas in other kids. Just so you can get a sense of this, again, this patient had extensive empyema here along the parafalcine region. I see this not too uncommonly. So the subdural empyema will wrap itself around the brain, and then sometimes in the posterior parafalcine region, it can loculate like this. This is a real challenge for the neurosurgeons frequently because they can't always drain this from one burr hole. So this is, again, why it's very important for us to make these diagnoses very quickly so surgeons can manage them before they become complicated. This is a kiddo who had, this is just a subdural empyema here below the frontal lobe, but he ended up with terrible cerebritis and multifocal abscesses here in the frontal lobe. You see the multifocal abscesses, and here are the enhancing margins of that subdural empyema, and it went into the parafalcine region. So these can be very, very serious with serious complications. All right, let's look at another case. The history, seizure and confusion from the emergency department. And I said, don't read too much into that, right? Don't think about that too much. But here it is. So another kiddo who comes to you, you're reading cases at night in the call room, and seizure and confusion. So we just looked at subdural empyemas, but this has a little bit different finding, right? Think about extraaxial spaces. So we have the axial unenhanced CT, the sagittal reconstructed image. Look at all the findings on the sagittal there. Give you a second, okay. So this is a different kind of extraaxial collection, right? So this doesn't wrap itself around the brain like the subdural collection does, but this is kind of that lenticular shaped collection, and it's crossing the anterior interhemispheric fissure here. So you see it on the sagittal images. It's this nice bilobe lenticular collection. The other thing you see again is our old friend frontal sinusitis here, all right? So this is the other intracranial empyema. So this is the epidural empyema, or the extradural empyema, as some people call it. So we also see this not infrequently in complicated sinusitis. In fact, I probably see this just as commonly as I see subdural empyemas. And you can also see these together. So sometimes we'll see an epidural empyema that secondarily will form a subdural empyema. So like all epidural collections, it has that typical lentiform shape. What's, again, typical for epidural empyemas is that they can cross the anterior falx, or, remember this, if you have an epidural empyema in the posterior fossa, say related to mastoiditis, these can cross the tentorium up into the supratentorial compartment. Subdurals never do either of these things. Subdurals don't cross the tent, they don't cross the falx, okay? So we frequently see these, again, related to frontal sinusitis in the anterior cranial fossa. So there's some other complications that we sometimes see going along with these epidural empyemas, the infamous Pott's puffy tumor and osteomyelitis of the frontal bone. So here's another epidural empyema on MR, post-contrast T1 axial MR, nice bilobed epidural crossing the anterior falx. And this one actually has a little bit of a subdural empyema also. So these are post-GAD flare images. So again, you see that subdural collection here extending around the right frontal lobe. Another small subdural and epidural empyema, so nice, pretty little bilobed epidural, and then there is the subdural. And the diffusion trace images, again, show it very nicely. They show the restricted diffusion from the pus in the empyema. Okay, so here's an epidural that has complications. So this one developed a subdural empyema, but this one also developed pretty significant cerebritis. And these cerebritis findings, again, could go on to abscess formation. So just in review quickly, epidural is focal lenticular. It doesn't spread around the brain like subdural. Subdural is more uniform, band-like all subdural collections, and it does extend around the brain. Subdurals don't cross the falx or the tentorium, and epidurals can cross the falx or tentorium. The bottom line is you can see either of these by themselves, or you can see them together. And they both displace brain and vessels. Epidural is usually more focal because they're confined to the intracranial fossa, usually. Subdurals, it's more extensive, and even a small subdural can cause very significant midline shift. All right, so here's another more to the story of the epidural empyema. So there's our little epidural empyema on the non-contrast study. Here's the contrast study. And you see the puffy forehead. So this is the subperiosteal abscess, the famous Pott's puffy tumor. So I love it. The history sometimes comes to the emergency department. The kid's got a puffy red forehead. And even they know Pott's puffy tumor. So we often get the history. That's what they're looking for. And we just start with contrast enhanced CT. So here's our Potts Puffy tumor kid. So we saw the epidural empyema and we saw the subperiosteal abscess, but we don't want search satisfaction because we've just been talking about these inflammatory empyemas, all the complications they can cause in the brain. So take a quick look. All right, so what's going on in this left frontal lobe, right? So the frontal horns, this looks like somebody is sitting on these frontal horns. They're really pushed posteriorly. Look at the asymmetry between the right frontal white matter and the left. The left looks expanded, it looks abnormal low density. So let me show you what's going on with this kiddo. So this kiddo had not only the subperiosteal abscess, the epidural empyema, but he also had an intracerebral abscess that shows so well on the ADC map. All right, you thought we're done with sinuses? Not quite yet. So let's look at another complicated sinus case. All right, so we're back to our old friend, altered mental status, a couple of images, post-contrast axial images, bone windows. Again, bone windows are our friend. So give you a couple seconds. We'll throw in the coronal image there. So the sphenoid sinusitis is pretty obvious, right? There's a large air fluid level here in the sphenoid air cell. So like all the other complicated sinusitis cases we just looked at, you have to ask yourself, what is around the sphenoid sinus? And if this thing extends, where can it go? So what's abnormal? Well, next to the sphenoid sinus is the cavernous sinus, right? So the cavernous sinus is just this big venous lake, basically sinusoids. The normal cavernous sinus is pretty thin. It actually has this concave lateral margin, and there's the carotid artery. Look at this cavernous sinus on this side. It's expanded, the dural margin is thickened, and it's non-enhancing centrally. Okay, same thing on the coronal images. Expanded, non-enhancing, actually got a little dot of air in it. So that's what cavernous sinus thrombosis looks like. So we just have to remember that the cavernous sinus sits there, and it's all these big venous sinusoids, these big venous lakes, and it does communicate across the midline. The other thing that's important to remember, there are a number of veins that drain into the cavernous sinus, including ophthalmic veins and facial veins through the ophthalmic veins. So when we get infection in the cavernous sinus, it can spread and cause more extensive thrombophlebitis. So this is that case we just looked at with the bad sphenoid sinusitis. So again, the nice normal cavernous sinus on the left, it's relatively thin. You see the carotid artery there, nice diffuse enhancement, big and large cavernous sinus on that right side with non-enhancement centrally. So that's cavernous sinus thrombosis. The other thing I'll tell you is if you look at that carotid artery is narrow. So there's this arteritis in the cavernous carotid artery on the right, and it's kind of a normal looking cavernous carotid on the left. So talking about veins and ophthalmic veins, this kiddo had supraophthalmic vein thrombosis, and you see all the inflammatory changes there in the superior orbit related to that sinusitis, cavernous sinus thrombosis. And here's the MRA, and again, this cavernous carotid here is just a little bit smaller on the right compared to the left. I've seen this a number of times. Kids aren't like adults. Kids tend to tolerate this arterial narrowing pretty well without infarcts. I'm an old guy. If it was me, I'd probably have infarcts all over my brain, but kids tend to do pretty well with it. This is another complication of sphenoid sinusitis in this same patient, and I've seen several of these cases over the years. So this is clival osteomyelitis. So this is the sphenoidal portion of the clivus. It goes down to the synoccipital synchondrosis here, but that's pretty bad osteomyelitis. Okay, so I wanted to show you a quick case. This was not intracranial. We needed a break anyway from intracranial. So this kiddo had 8-year-old with neck pain and gland swelling. So take a look. This is a part of the coronal neck study with contrast, axial images up high. So we see the asymmetric swelling in the lateral rectopharyngeal space. I see these all the time. Probably almost every call night I see one of these. So a little lateral rectopharyngeal abscess here. These are, I don't want to say a dime a dozen, but we see these all the time. You might say the carotid artery here is a little bit narrowed compared to the other side. It is a little narrowed. We also see this not uncommonly. There's literature out there that says that you can have complications, but they're fairly rare. So this kiddo came back 12 days later for worsening neck pain and swelling. And so that abscess got bigger. And there's a lot of swelling in the lateral rectopharyngeal space. But look what's important here. There's this large patchy area of contrast enhancement here at the skull base where that abscess is located. And this is the contralateral, the right carotid artery as it goes into the skull base. And that artery is right here. So there's a large amount of contrast associated with that artery. So let's look at the sagittal images. So that's the normal right side, nice normal internal carotid artery going up to the carotid canal. This is the left side. There's that obvious finding with that large patchy area of contrast enhancement. And look at the size of this abscess all around the carotid sheath. So what is this? So this is a mycotic pseudoaneurysm, right, related to that abscess. These are rare, but we've seen a couple of these now. And just to show you the angio to prove it, that's a very ratty, nasty looking internal carotid artery there just before it goes into the skull base. And there is the pseudoaneurysm. And then it was coiled in the same procedure. So you probably won't see many of those, but I wanted you to see that. That's a recent case from our children's hospital, and it's something you have to keep in your mind when you're looking at these big, complicated neck abscesses, particularly when they're around the carotid artery. Okay, so let's go back to 3-year-old female with headache and ataxia. Okay, axial CT images, take a quick look. No contrast here. Remember the history, headache and ataxia. All right, so here are the findings. So we have a lot of low density here in the cerebellum, deep cerebellum, cerebellar white matter. What else is abnormal? Well, there's a lot of crowding in this posterior fossa, and that's the fourth ventricle. That fourth ventricle is massively compressed, really squeezed. So this was the follow-up MRI, and it really, these are the FLAIR axial images, and it really shows all of that edema, massive edema in the deep cerebellar hemispheres, and that's the fourth ventricle. Somebody might call that a keyhole fourth ventricle. It's like the slit in the door where you put your key now. That is massively abnormal. That's reflective of the severe posterior fossa mass effect, and that's because of all this edema. And all the premedullary, all these cisterns are pretty tight on this kiddo. So this is acute cerebritis, and we do see a few cases a year of this. This is one of those things you have to look for because this is critical. I've actually seen a patient death from this when it was missed early on. But these are the findings, all that deep white matter edema. You won't see a focal tumor. You might wonder, is there like an astrocytoma? There's not. There's just diffuse edema and carotid posterior fossa. This is usually post-viral. It can be after chickenpox. It can be typically 10 days after the onset of rash. But if you see a tight posterior fossa with edema, you've got to think about acute cerebritis and let the clinicians know. Okay, back to our history, altered mental status. So this is a tough case, but I'm showing you this because we see several cases of this a year. And if you look at this head CT and call it normal, you'd be in pretty good company, because the findings that are there are very subtle. So these kids, though, I'll tell you, are very, very sick. They're typically seizing, they're often confused, lethargic, and they often go right to the ICU. So they get scanned, regardless of what the CT shows, usually the next day. So here's the MR, the axial FLAIR images. So it's pretty grossly abnormal, right? So you see multifocal, patchy areas of abnormal T2 signal, deep white matter, subcortical white matter, deep gray nuclei, thalami, basal ganglia. It could be in the brainstem. You see it here in the corpus callosum. It's just scattered all throughout the brain. You look at the architecture of these lesions. They're not typical MS-type lesions, but they're kind of similar. And that kind of gives you an idea of what this diagnosis is. All right, so let's put that FLAIR axial image back up with the CT. Maybe there's a little subtle low density here. I tell you, I don't know how we call the CT. We may have called it normal. I've read these as normal before and then been amazed looking at the MR the next day, but this is pretty typical ADEM. So this is classically post-vaccinal or post-viral immune-mediated encephalomyelitis. Most of the time, the history I see is post-viral. They've had an upper respiratory infection. So this is the cascade clinically, from headaches all the way to loss of consciousness, in fact, and seizures. You have to remember they can have myelitis in the spine. And so usually these kids get screening spine studies too. There's a very severe form called acute necrotizing encephalitis that's classically post-influenza or herpes virus 6. But there is a recent case reported in an adult following COVID-19 that was published in the Gray Journal. So this is a kiddo that had A&E, acute necrotizing encephalitis, diffuse abnormal white matter. These are FLAIR images. It's a young kiddo. So this is incomplete myelination, subcortical U fibers, deep cerebellar edema. This is the ADC map. This is just necrosis. That's why it's called acute necrotizing encephalitis. It just causes severe necrosis in the white matter and the gray matter. The abnormal MR spec with elevated choline and large lactate doublet here. So this is the case reported end of March in the Gray Journal, an adult. This was presumed to be post-COVID-19. This is pretty classic, bilateral thalamic edema, and you see multifocal little areas of necrosis in the thalami. And in fact, this had multifocal little areas of hemorrhage. So think about that. Cases that look like A&E in this day and age could be post-COVID also. Okay, so we're going to round this out here and finish with ear pain. We couldn't exclude ear pain, especially if we're doing a favor for our ENT surgeons here. All right, so this is pretty obvious on the bone windows. A lot of cortical erosions here in this temporal bone. That's a nasty looking ear. Even the bone windows, you can see the swelling. The contrast images, and what we do in these kids is we typically, when we're worried about mastoiditis, we do a post-contrast head and do coronal and sagittal recons because we want to see the intracranial compartment as well as the ear. So here are images a little higher up. You see this big, huge periauricular abscess, but we're talking about the intracranial stuff. So what's going on the intracranial side? All right, so we have all this enhancement and non-enhancement. So what should live out here normally? Big vascular structure, right? Sigmoid sinus, we have transverse sinus coming down, sigmoid sinus, there's non-enhancement there. There's probably a little empyema here. You see no enhancement on the left side. There's the nice normal dural venous sinus enhancement. So this is a pretty common complication of mastoiditis, right? So this is dural venous sinus thrombosis. We not uncommonly will see small intracranial empyemas adjacent to these thrombosed veins. And there is the MRV. So there is nothing left on that left side. We've got a huge, nice, big sigmoid transverse sinus on the right, which is good because this is the major venous outflow. So I just put this slide up here. This is not that patient. This is actually a patient I read the other day who had cochlear implant and actually had infection related to the implant. But you have to remember to window and level for that dural venous sinus. So that has to be in your checklist for complicated mastoiditis. You've got to, this is kind of normal bone windows, or normal, parenchymal windows, where the dural venous sinus lays right up against the bone. So you really can't see it. So you have to force yourself. Remember, I've got to window and level to make sure I see those dural veins, to make sure they're patent. So there I've windowed and leveled so that I can see really nice dural venous sinus enhancement. No evidence of thrombosis. One last quick case here. Another kiddo with this time right-sided ear pain. So you see all the fluid here, tympanic cavity, mastoid antrum. We don't see a lot of osseous erosions here. This is the axial, so this was actually the unenhanced axial CT head that we did, I think probably mainly for the history of headache. So there's something going on here, right? So we are, here's the tentorial edge, we're above the tent, right? So there's this, remember back to earlier in the talk, we had this kind of elliptical lenticular form mass here, and there's this edema in the adjacent brain. All right, so those are the findings. So we actually got an MRI on this kiddo. So we have T2 coronal images here. So there's an epidural collection, that's an epidural empyema here that came out of this mastoiditis, and this one crossed the tent, all right? So we went right across the tentorium into the supratentorial compartment and see all this edema and mass effect here on the brain. There's actually an abscess. So this kiddo had not only epidural abscess, he actually has supratentorial intraaxial abscess related to his mastoiditis. And the diffusion shows that so nicely, the intraaxial abscess here, and here's that epidural empyema that crossed from the posterior fossa up into the supratentorial compartment. And here's our post-contrast MRV, which actually again shows this kiddo had dural venous sinus thrombosis. You see the enlarged vena flavae, which is the collateral venous flow here. And again, it's really good for this kiddo that he's got a nice, large, left-sided outflow. All right, so this is my checklist with mastoiditis, periauricular abscess, dural venous sinus thrombosis. Look at the cerebellum, make sure you don't have cerebritis. Make sure you don't have something going up in the supratentorial compartment also causing abscess. Look for those empyemas. We often follow these up after surgery with MRI to look for these complications. All right, so that's Colorado. That's South Central Colorado, and it would be nice if we could all be there. That's in a September after a storm. Thank you for letting me teach you this afternoon, and I hope the best for every one of you in your careers. Take care.
Thank you so much, Dr. Morris. And again, thank you, Dr. Madan, for two really great lectures and beautiful imaging showing the cases. Thanks to all who attended, and we'll see you on Thursday for emergency imaging for our next session. Be safe, everybody, and take care.